this patient, if we had did the initial staging for the patient, and we found that the patient actually had not only the large lymph node in the superficial groin, but also had numerous lymph nodes along the external iliac and common iliac area and going up towards the bifurcation of the iliacs and the aorta. So from me as a surgical perspective, could I resect that? It's very possible it's resectable, but it truly is borderline from the perspective that the risk of this patient recurring is very high. And we really, as surgeons, think about this is that surgically I could take this out, but as soon as I move the patient from the operating room to the recovery room, they probably are already recurring. So I would say it would not be a meaningful surgical resection. So in this setting then, I know that there are some ongoing neoadjuvant clinical trials right now, and I know both you, Mike, have done some at MD Anderson. Georgina, you've done some in Australia. So tell me a bit about the studies that you have conducted and sort of some other ongoing studies that you have at the moment. So Georgina, tell me.
So again, as a surgeon, you are still telling me this is resectable, really. It's just extensive and you know they're going to recur quickly.
So in surgery, nothing is black and white.
Right.
And I would tell you that surgically we could potentially take this out, but this is not a meaningful operation due to the risk of recurrence, which would fall really under the category of unresectable because of its the futility of the operation to render the patient free of disease for a reasonable amount of time.
So it's not black and white, and at our institution, something that can be chopped out is considered resectable. So it would be considered resectable despite all the caveats about the fact that the patient almost has a 100% chance of recurring, near 100%. So we would consider neoadjuvant trials. They're eligible in our institution. For our neoadjuvant trials, the surgeon has to be able to say, we can remove this as is on block, leaving no melanoma behind, getting good margins. And we would consider, so we've got several neoadjuvant trials. One of targeted therapy for BRAF V600 mutant patients. It works very well. We've completed enrollment of that. We've done one look-see in the first 19 patients. It is very much a translational study, so looking at biomarkers. And in that trial, we had 50% of patients have a complete pathological response, complete resist response, and complete metabolic response after 12 weeks of neoadjuvant dabrafenib and trametinib. The question of how much dabrafenib and trametinib you need, I don't think you need 12 weeks. I can think you could do it with 8, possibly even 6. I don't know what the pathological response rate would be, but I think it would be near what we see at 12 weeks, given what we see in the metastatic setting. The other study we have about to open is neoadjuvant combination nivolumab and ipilimumab. Again, this patient would be perfect for that. We have some, again, early data from the Netherlands in that situation where the first 10 patients, 3 of them had a complete pathological response by week 6. So that's really compelling and interesting as well. There's also mouse data that suggests if you have the tumor in situ and give immune therapy, you actually may induce a better immune response rather than chopping it out first, then giving it adjuvantly. So maybe the neoadjuvant approach is better, but we don't know the answer to that. The third trial we have, which I find very interesting and important trial as well, is again, neoadjuvant has to be resectable. This time it's for BRAF mutant, but it's looking at 3 arms. How do we combine targeted therapy and immunotherapy? So it's dabrafenib and trametinib followed by pembrolizumab for 12 weeks, all 3 together, or just anti-PD-1. So it's going to answer a whole heap of questions about sequencing in terms of translational tissue endpoints. So they're the neoadjuvant trials we have open at the moment. We plan to continue to use this neoadjuvant platform. We've got a lot of work to do in that space, but it is only on clinical trial. That's the important point.
Mike, you led a neoadjuvant symposium recently talking about this, how we sort of evaluate these patients. You've also done some studies at MD Anderson, very similar to what Georgina has, that you've done with BRAF-MEK combinations, as well as some studies as well with immunotherapy for this. Tell me a little bit about those studies that you've done.
Yeah, so our first trial was for patients with BRAF V600 mutation. This was actually a randomized clinical trial randomized in a 2-to-1 fashion where 1/3 of the patients got randomized to standard of care surgery and were offered standard adjuvant therapy. And then 2/3 of the patients were randomized to neoadjuvant treatment with dabrafenib and trametinib for 8 weeks, followed by surgery. And then after surgery, they then had an additional 44 weeks of adjuvant treatment to complete 1 year of therapy. This trial was actually stopped early by our DSMB because of the marked difference in relapse-free survival we saw between these two arms, which made it unethical to continue to randomize patients to standard of care surgery. This data is going to be presented actually in full in just 2 days, and will certainly then be available to the public. That trial is then going to reopen to be very similar to Georgina's trial, to not have randomization to standard of care, but to simply be neoadjuvant therapy for 8 weeks for each patient who has this BRAF mutation. We actually, again, with this eight weeks of therapy, had a very similar path CR rate of almost 60% that was seen in the Australian study, suggesting that 2 to 3 months may not be that different, at least in terms of how much therapy it takes to see a path CR. We have another trial open in which patients are randomized to neoadjuvant treatment with single-agent nivolumab or combined treatment with ipilimumab and nivolumab. And that trial is really too early to have any reportable results, but does again reflect this hypothesis that neoadjuvant therapy may have, again, significant clinical benefit, and certainly, again, as we try to understand why some patients respond better than others, why resistance happens, a very powerful opportunity for us, hopefully, to understand resistance and develop the next generation of therapies. Certainly, one of the ultimate questions is whether this becomes a standard approach, as is used in diseases like breast cancer, where neoadjuvant therapies are even actually a way that new therapies can gain regulatory approval. And this, again, was one of the things that was discussed at that workshop that you mentioned. And again, is something that is only now feasible because of the marked developments we've made with much more effective targeted and immune therapies. Again, just to though reinforce, this is something that really should only be done in the setting of a clinical trial.